color, you can rely on the basic kit and you can complain for weeks. A little masterpiece in terms of the utilization of porcelain. It's an implant case. As you can see, we did an individual healing abutment. A little bit different as you have seen it in the morning. We made it with CAD-CAM and a T-platform. Then we made the color selection. We took pictures. We used the cross-polarizing filter to see all the little hidden effects internally. And then, yeah, the patient came. We took pictures. We made the abutment, an individual abutment, bonded on a T-platform. And then finally, we got the first case. We controlled the first bake, sorry, not the first base, the first bake. We controlled all the internal color effects. They were stained and fixed. Then we took a picture with the cross-polarizing filter to control and to compare if the effects are too strong or if they are good. They were good, and then the try-in procedure came. We placed the implant. See, the response of the gum is really just perfect. And then we placed the crown, and that's the first bake in place. And now we were just up to make a decision what kind of filter we bring up, what kind of enamel. We decided to use a pretty dense enamel. We did our second bake, and that's the result. That's the result in the laboratory. We just placed the implant, we placed the crown, we polished everything, and then a few weeks later, she came back, and then we got the final shots. Even the black and white picture, even here you can't see that it is a faked version. It looks like a natural tooth. And even this picture where you got the chance to combine the natural tooth with the porcelain one, with the cross-polarizing filter, there's not really pretty much a distance. And this is what I said in the beginning. This is for me the understanding of high quality in our days by using the material and bring it really up to the limit. And the last picture was taken 2 weeks after, where you see the fillings, they were replaced, and now we were able to close this chapter. I think I made it pretty much in time. I thank you for listening, and it's an honor to give the show over to Daniel. Thanks a lot.
So Oliver and me, we are working together since about 10 years already. I like to give you, in my part of the lecture, a certain review on the complex cases, especially of the occlusal cases. So I come from the University of Munich, as you know, and what we have always to focus, and I think that is the message of this Congress, is that the most precious material for restoration is actually the tooth itself. So it's an enamel. And it's a very important person who told us this sentence. It was actually John McLean from London. So don't touch natural tooth structure if it's not necessary. But in some cases, as you can see, teeth are not built for eternity. You see some exposure of the dentin over here, and you see that can affect also biomechanics. So we need for the future some solutions which can repair teeth which are worn. And you know that we have seen different options to do that today. So the longevity of natural teeth are the highest that you can ever accomplish. So the survival rate over 99.5 over 50 years is 99.5%. That means you have an annual failure rate of only 0.01%. And we have seen in different of our lectures today that the annual failure rate of restorations are normally in around 1.5%. So this is the material of choice. But however, teeth are not made for eternity. As you can see, even older teeth of this 75 years old lady is in the range of, it's like an inherent aesthetic. outcome inside. But she complained about the length of the teeth, about the shape and the shade of the teeth, so we can change it in the future. But we also see younger patients like these. They come into your office, they will ask for new fillings in the anterior aspect. But you see on this picture, without any examination, that there's something wrong with the whole occlusion. She has a traumatic bite. This is shown by the opening of the contact points already. And you see that we have some problems, and I told her, first of all, we have to restore the posterior teeth to increase the vertical dimension of occlusion, and then we can do something on the anteriors. This is the concept. She didn't believe me. She quit my office and she never came back. If she waits too long, it will look like this in 10 years. In another 10 years, probably like this. And these pictures should show you that we come to some certain limits. We have still enamel available, but this is almost the border that you have to cross. 1 square millimeter of enamel provides you 3 kilograms of bond. So you can bond 3 kilograms onto 1 square millimeter of enamel. So now you can calculate the square millimeters and you can see how much you can bond on it. Worn dentition, the wear of dentition by erosion or by mechanical measures, it's nothing new. It was described already very early, and it's an international increasing problem. The problem is also that if dentin is exposed, we have an acceleration of the wear up to 10 times. This is something, and it's a very important information for you as a dentist especially, that you have to interact. You have to find solutions to solve these problems. If you wait too long, you will risk to have a further reduction of the clinical crown length. You have also surgical crown lengthening, which is sometimes necessary, which is an attachment loss. Root canal treatment may be necessary because root canal treatment can also involve a post which creates retention. But if you're doing nothing, you will lose the tooth. This is a problem. And now we have to find solutions for these patients. So if Francesca Vailati would be here, she would say, I'm treating monsters, no actresses or others. So these patients suffer because they are losing the lower facial third. As you can see over here, they look completely different, and there's not an aesthetic appearance anymore. So we have to find solution for these cases. What can it affect? If you lose vertical dimension of occlusion, it can affect masticatory function. It can also affect the speech. It can also affect, on the long run, the TMJ by compression, because you lose the height, the dental height, and then it can be compressed in the TMJ area. But do you know why the patients are coming to your office? Predominantly because of aesthetic problems. Not because of pain or functional problems, not because of sensitivity. The main concern is aesthetics. And we have nowadays options to make them looking nicer. Very easy options. We can use tooth-colored splints to do a test drive. We just described that in the newest issue of Quintessence Dental Technician this year. So this is a test drive for the patient. He simply received tooth-colored removable splints according to the wax-up that Oliver can deliver me. So he can test drive it aesthetically and functionally with a very high compliance. This is one option, and of course we change a lot. The height that we changed was in this case 6.5 millimeters. This is a lot. Can you do that? And I can tell you, yes, to a certain limitation, yes, but you need sometimes, especially at this height, a higher, a longer, an extended pre-treatment phase. This is possible. So according to this study, 5 millimeter increase of your vertical dimension of occlusion, it's actually a predictable procedure and accepted. So this is nothing, not a problem actually. It's more the problem if you are using patients which have 7 or even more millimeters to VDI, vertical dimension of increase. And you see, when we have increased the posterior bite, then we can really restore the anteriors. And we have done that on this young lady of 17 years old. And we used composite veneers for the posteriors, occlusal veneers, and we used porcelain in the anterior aspect. We did the same with this lady. And you will complain it's a certain asymmetry in the face, but look at her. I go back again, sorry, how she looked like before. So it was some problem also with the buccal corridors. You can see over here, we corrected all that. And it was a cooperation together with Otto Zur, who is a periodontologist in Munich. So this was something very important. And I think the main goal that you should have is look at the details, look at the signs of function. You see some fractures over here in this tooth. You see cracks in this anterior aspect. And the first step that you always have to decide is posterior teeth will protect the anteriors in static occlusion, and anterior teeth will protect the posteriors in dynamic occlusion. This is a rule. This is a rule that we have to follow. And how can we do that? So if we have patients like this with a severe wear, we expect that we lose vertical dimension of occlusion by the posteriors. And so what happens? Mostly a development of class 3 edge-to-edge position. And if you have periodontally compromised teeth, sometimes there are changes to a fan-shaped anterior dentition, like it's shown over here. So what you can do now in the first step is reconstruction of the posteriors, and then you have the space to reconstruct the anteriors again or to perform ortho. This is the whole concept that you can follow after analyzing the whole case, and this must be always conducted together with a dental technician in your dental team. So we can use now very easily some certain guidelines to reconstruct anterior aesthetics. We can follow the recommendation of Christian Stappert and the group of NYU around Dennis Tano. We can regenerate the papilla height, the contact area. And also we can follow the recommendation of Pascal Magnier according to the width to length ratios. This is nothing new, but we can follow these principles for our wax-up. Very important information. So Oliver and me, we restored a lot of cases. I would guess about 10 complex cases in the last, I would say 7-8 years. And this case actually was one of our first. That was a patient with a dentinogenesis imperfecta. And you see him in the age of 14, 15 on the left-hand side. And we did a try-in in 2006. We did a test drive with the provisionals, which were made out of polymer, a new polymer, which was experimental at this stage. And then finally we turned that into the final restoration. The question is now, how long can they stand it, this new situation? And you see we have pictures now. I just did a recall on him in 2014, this June, in the beginning of this month. And it was actually last week where we took these pictures, and you see it looks great, it works. And the principle was nothing else than using staining technology, monolithic approach for the posteriors, and layering for the anteriors. This was after placements, this was after 36 months of clinical service, and this is 58 months after clinical service. And you see they are still working nicely. And these pictures should really convince you to change your mind that you need monolithic zirconia. It's working with lithium disilicate ceramic if you use it in this described version that you have seen over here today. And you see again from the lower jaw, no changes, not so much changes in the morphology, not so much changes in the color, perhaps a little lack of glaze after almost 5 years of clinical service. So according to crowns, I can really convince you that works out, even if you are using crowns with stratification, with veneering on the top, which are based on lithium disilicate ceramic. You have a survival rate after 8 years of almost 95% according to our studies. This is still a group of patients that I restored in the Aachen University. So we need new approaches, especially if you have patients like this, and they are very often in your daily practice. A worn dentition, complex case, we follow all the principles that you have seen. We have a strict protocol to be followed. We do an aesthetic evaluation, which is based on the diagnostic wax-up. We always try to restore in occlusal stability in centric relation. We evaluate the increase of video, and you have also to include a functional test drive. Otherwise, you cannot really succeed. So this is an important protocol that we follow on him. So this was done in 2008. This is one of our complex cases in one of our studies. And you see Oliver did a nice work. He did a very nice wax-up. We can even check our dynamic occlusion by the mock-up. This is very important. We are using flowable composite for doing that. And we thought about to place an implant, and we did a test drive with a prototype of the Teleocat at this time. So this is a color which is not very favorable. It's changing now. We have HD ingots. At this time it was not possible to access, and that was the whole first step of functional test drive. So it's not a removable splint, it's a permanent splint, which are much more efficient to test drive something. So we did so, and we please note those are single tooth restoration bonded to the dentition, which was worn by mechanical and erosional reasons. So you see this, the case that was 2008. The patient did not appear for 3 years, and he came back to our practice at the year of 2011, and you see what happened. What happened? Look at the details. A lot of wear all over. I show you magnification, so we can say, please keep in mind, this material, Teleocat, is good for 1 year. It's based on PMMA, unfilled, and this is, of course, shows a higher wear rate, like we will see later on, like composite-based or polymer ceramic-based materials. So finally, we changed that into the final ceramic. I had some protocol to follow. It's 1 millimeter thickness of the occlusal veneers. That was the definition for the study. We can now segment our whole treatment into different steps. And I did a slight preparation. I always try to keep over above the equator. If you access the undercut, you are very invasive. Always try to keep over the equator. So Oliver did a very nice job. These are monolithic lithium disilicate restorations. In the anterior aspect, we were using cutback technique. Oliver used the cutback technique, and we were using this, we call it full wrap veneer or 360-degree veneer. In this case, it looks still not perfect because we have some inflammation of the gum area, but look, after 2 weeks, we have a perfect outcome of the aesthetics. And please remember well, all these cases that I show you are cases with a parafunctional history. They are all involved in parafunction. So we came from here to here. This is man-made. On the left-hand side, it's machine-made. And I absolutely agree with Oliver. This level that you see on the right-hand side, you cannot reach with the machine. Impossible. Man-made, machine-made. So again, we just had a recall on this patient. This was, by the way, 2012, beginning of 2012, after the whole treatment. This is
2.5 years later, you see him, it changed a little bit, and we are always very, very interested what happened. And we took pictures, and you see, this is 2012, this is 2.5 years later, and you see some wear facets, extremely high wear facets over here. You see the canine? So he follows again the pre-existing patterns. And this is something we have always to keep in mind, that they go back into the patterns that they have. Even he's wearing a night guard, the compliance is very low, I have to say. You see the wear rate is not only shown on the veneering ceramic, it's also can be seen on the lithium disilicate ceramic. So this is something bad, it's something positive. I mean that you have your own patterns in this dentition. This material shows you that it's capable for doing that. And again, this was a lower canine, and this was made by Emax ceram veneering material, and we have observed a lot of wear also and wear facets in these patients. So what we can say now as a conclusion, we can see clinically, and this is confirmed by in vitro studies, that the highest material wear will be shown by PMMA, by disilicate, for instance. Composite, it's a little more wear resistant, but the highest wear resistance is shown by the glass ceramic. If you now look to the enamel wear, the opposing tooth structure, it's reverse. So PMMA is the nicest material for the opposing tooth structure. It's composite, it's somewhere in between, and glass ceramic is actually the most, I would not say aggressive, but more stable, the most stable material that you can use. If you look for monolithic zirconia, it would be somewhere here. It shows in our in vitro studies nowhere, zero. So this is important information, and we like to look at some other studies. After 3-year clinical evaluation, we can find for lithium disilicate a wear behavior which was superior to another all-ceramic crown system. It was one from Nobel Biocare, and it was comparable to metal ceramic crowns. So we have proof that it's relatively wear-resistant. What we can, if you would ask me now, what would I have done different nowadays? The only thing that I would change nowadays is actually that I would put another concept to the implant. And this is the concept abutment solution that we published last year already in several patients. We are using this now. It's one piece, abutment and crown, one piece made of Emax CAD. Another patient of our study that I like to show you, this is an ice hockey player, and he has some problems because of erosions, mechanical wear, and of course fractures because of the sports. So you have seen already the pictures before, the very distracted anterior teeth, and Oliver did a very nice work on him. We placed this whole work in 2011. Now we had the recall after more than approximately 3 years, and you see what happened. Actually nothing. It works nicely. We have increased the bite by 3.8 millimeters, and we came, believe it or not, from here. That was the initial situation. So we have still enamel available, circular enamel. We did the test drive with disilicate. Again, this is PMMA, and then we transformed that into the final restoration, which is cutback and not staining technique, only staining technique for the posteriors, but we have the stratification technique, the veneering technique for the anteriors. This is the situation after almost 3 years. Same from the anterior view. Look at the relation between papilla height and the width to length ratio. We came from here, we have this situation now, and then again about 2.5 years later. This is the situation for the posteriors, again, 2012, 2014. It works, and we again can see, like in the other patient, that we have some wear facets. So I show you this picture only to really convince you that this material works nicely. In our study, with a total of 111 occlusal veneers solution with lithium disilicate, we had no failures. Where did we have failures? We had failures in the anterior aspect, some shippings of the canine veneering material. We have not to exchange something, so it was minor complication, but however, we had some chipping, I have to be honest, and the main reason is actually that the patient have a very bad compliance according to the night guards. They are not wearing the night guards, because you know all the bad things are happening between sunset and sunrise. And for this time period, the night guard will be helpful. So what is the new trend? I go back again. What is the new trend? We see in all the different universities now looking for thinner restorations. And we do some research, especially Karl-Heinz Kunzelmann, and this is one of the students of his thesis. We did some research in our university, in our dental school, and we have seen that you can thin out even Emax CAT or Emax press as well. Especially it's dependent, that shows the study of Marr from the US, of NYU, that we can thin it out dependent on the substrate below. If it's enamel, you can thin it out much more if in comparison to dentin support. So it depends strongly on the support of the material that's available, and that makes sense. In other words, you can use thinner, probably, we need clinical trials for this to confirm that, we probably can use thinner occlusal veneers if we have still enamel available, because the elastic modulus is much higher, and we need thicker ones if dentin is exposed. It makes sense because it depends on the morphology of these teeth, of course. So this is the last picture, and it's also a nice picture which can a little bit go into your heart, because these are the materials. It's a desert of the Sahara, northwest of Africa, and I had a very nice trip in this area. The picture was taken by myself, and this is the raw ingredients that we have available, and we have to thank the companies like Ivoclar that they make nice things out of it, like Emax or others. So thank you again providing these materials, and thank you providing us new treatment concepts. Thank you very much.